Let's jump right into morning clinical rounds with a pretty complex case. We're looking at a 44-year-old male presenting with a massive, non-obstructing struvite staghorn calculus.
So what's the preferred primary interventional treatment modality here? We've got this massive stone burden, right? How do we effectively manage an extensive pelvic and pole calculus like this without triggering a cascade of further complications?
The answer is B, percutaneous nephrolithotomy, or PCNL. For large, complex stones like this, PCNL is absolutely the gold standard. You see, if we relied purely on shock waves, like ESWL monotherapy, we'd literally create an overwhelming avalanche of fragments. That avalanche severely clogs the distal ureter, leading to a highly dangerous complication we call Steinstrasse, which translates to a street of stones. With PCNL, we establish a direct percutaneous track right into the renal collecting system. It's a game changer because it allows us to break apart and extract those fragments safely.
Okay, next up. A 34-year-old male presents with severe, constant left loin pain that radiates all the way down into his scrotum. He's nauseous, he's sweating, classic acute ureteric colic. But what is the absolute gold standard rapid imaging modality for this?
If you guess D, a non-contrast CT scan, you hit the nail on the head. The sheer efficiency of this scan is just incredible. We're talking about a sensitivity and specificity well over 95%. It acts as the ultimate diagnostic tool because it's incredibly fast and it quickly spots even radiolucent uric acid stones. Plus, it can completely rule out alternative, life-threatening non-urological causes like a leaking abdominal aortic aneurysm, all without the risks of a contrast allergy.
Moving on to a critical pediatric emergency. We have a 10-year-old boy who presents looking incredibly toxic. He's highly septic, experiencing rigors, and has a left pelviureteric junction obstruction complicated by pyonephrosis. Think fast. What immediate interventional step absolutely must be taken?
The right move here is an ultrasound-guided percutaneous nephrostomy, or PCN. Here's why. We have to place a PCN tube immediately because the thick, purulent pus associated with pyonephrosis will instantly clog up a thin, narrow internal double J stent. That would lead to a fatal drainage failure. By using a wide-bore PCN, we get direct external drainage that safely clears out all that thick pus without risking retrograde bacterium.
Now imagine a surgical team managing a massive 3.5 centimeter branching struvite staghorn calculus that's completely filling the left renal pelvis. Which multimodal interventional strategy is best suited to clear out a stone burden of this magnitude?
For something this massive, you want primary PCNL combined with adjunct ESWL sessions. Based on the standard management boundaries, anything over 20 to 25 millimeters automatically mandates percutaneous nephrolithotomy to debulk that central mass. Once you've done that heavy lifting, you follow up with targeted ESWL sessions to shatter any inaccessible peripheral calyceal remnants. It's a highly effective dual paradigm.
Now, what if we're using ESWL to manage smaller renal calculi, say under 1.5 centimeters? It's really crucial to know exactly which patient conditions make firing those high-energy acoustic shock waves dangerous. So which patient profile represents an absolute contraindication to an ESWL session?
Active pregnancy is a hard stop. It's an absolute contraindication. Firing those high-energy acoustic pressure vectors can cause catastrophic placental abruption, induce a spontaneous abortion, or result in severe fetal structural damage. Absolutely no way. Other absolute contraindications you need to memorize are uncorrected coagulopathy and acute urosepsis. Things like morbid obesity or renal artery aneurysms, those sit in the relative contraindications category. Shifting gears to neonatology. A male fetus has an antenatally diagnosed third trimester right-sided hydronephrosis. We're suspecting a PUJ obstruction. But postnatally, the infant looks perfectly normal, feeds well, and voids normally. What's our next step?
The correct move is B. Repeat the ultrasound scan in 1 week. Here's the deal. Many congenital PUJ obstructions are really just transient delays in the system's maturation, and they often improve completely on their own. So the best approach is to give it a week. Let the infant's volume status normalize, and then take another look. We definitely don't want to rush into an Anderson-Hines pieloplasty unless we see progressive dilation or a drop in differential renal function on a MAG-3 scan.
Let's look at a really tense scenario. A 55-year-old male rolls in hypotensive and septic. His blood pressure is tanking at 90/60. He has a completely non-functioning left kidney and a massive paranephric abscess. What is the immediate management step here?
It all comes down to the stability pivot rule. If the patient is stable, you can perform a primary nephrectomy. But if they're actively unstable and septic, like our patient here, percutaneous drainage is strictly mandated first. Rushing this unstable patient into an open nephrectomy carries a massive perioperative mortality risk. Your only safe choice to control that septic focus is image-guided percutaneous drainage and IV antibiotics, before even considering a staged elective nephrectomy.
All right, check out this fascinating presentation. A 22-year-old female comes in with a recurrent right flank ache. But here's the catch. It's specifically worsened by heavy fluid intake, like binge drinking, and then it's completely relieved right after she passes a huge volume of urine. What exactly is going on here?
This is a classic Deidel's crisis. It's caused by a primary pelvic-ureteric junction obstruction. Basically, the patient chugs a bunch of fluid, and that rapid urine production completely overwhelms a narrow aperistolic Puj segment. This sudden functional bottleneck causes acute, painful distension of the renal pelvis. But eventually, that trapped fluid manages to pass, the distension drops, and boom, the pain completely resolves.
Let's scale up that pyonephrosis emergency we saw earlier. Now we have a 48-year-old male admitted with severe loin pain, high fever, and pyonephrosis. But this time, it's in a solitary, functioning hydronephrotic kidney. What's the immediate next step?
Option E. You have to place a percutaneous nephrostomy, or PCN tube, right away. Just like in our pediatric case, sepsis mandates reliable external decompression for that thick, purulent fluid. But here, the solitary kidney mandate kicks in. This turns the situation into an absolute race against the clock to prevent irreversible, decompensated acute renal failure. You literally cannot waste a single second.
Okay, returning to the Puj. We have a 30-year-old male with a 1-centimeter recurrent stricture at the pelvocalial junction. The catch? He had an open pyeloplasty 3 years ago. What is the preferred minimally invasive next step?
The best move is B, an endopyelotomy. Doing a reoperative open surgery here is notoriously difficult because of all the dense periureteral scarring from his previous procedure. So we prefer this endoscopic approach using a cold knife or laser incision directly from within the lumen. It actually boasts a high success rate of 75 to 89%. That is, as long as the stricture is short, under 2 centimeters, and you've confirmed there are no crossing lower pole renal blood vessels sitting right in your incision path.
Now, for a bit of urologic oncology. An asymptomatic mass has quietly invaded major vascular structures. We have a 62-year-old male with a 5-centimeter, solid right kidney mass, and it's extending into the infrahepatic inferior vena cava, specifically below the diaphragm. Based on this, what is the correct TNM classification?
Based on the TNM staging matrix, macrostructural extension directly into the IVC below the diaphragm categorizes this devastating renal cell carcinoma firmly as a T3B lesion. It's pretty straightforward to visualize. T3C would mean the gross tumor thrombus extends above the diaphragm, while a T4 stage implies the tumor has aggressively invaded straight through Gerota's fascia.
For our final case, we've got a 26-year-old pregnant female in her second trimester. Her ultrasound shows alarming results. Mild to moderate bilateral hydronephrosis, yet she has absolutely zero clinical symptoms. What's the primary underlying cause here?
Well, it's actually just normal physiologic pregnancy changes. Hormonally, her high circulating progesterone chemically relaxes the ureteric smooth muscle, which significantly slows peristalsis. Mechanically, that expanding gravid uterus is physically compressing the ureters at the pelvic brim. Interestingly, this compression strongly favors the right side because the sigmoid colon acts like a protective cushion on the left. It really leaves you to wonder how many other routine physiologic changes mask themselves as critical surgical emergencies on our imaging.